case, and since it's the worst case, I think this was the first tough case I had in my life almost 11 years ago. This is a 72 years old gentleman, hypertensive diabetic, symptomatic over 15 years, refusing surgery, severe varus, flexion deformity, limited range of motion, more on the right side, and had significant medial cortex, medial tibial bony defects. Well, these are the x-rays, AP standing. And these are the x-rays lateral. Certainly much easier than what previous speakers have said, but I still choose to present because a lot of us are going to have it, and there are plethoras of choice you can make it on table to treat this case successfully.
So does anyone on the panel want to tackle this one? Come on, someone step up.
So this is a fairly standard situation that we face in arthroplasty practice in this country. And I think there's obviously the problem here is, number one, there's bone loss. You will have to address that either with hardware or with a graft. Then the second is the instability, and there's a significant lateral thrust, which means that the LCL and the lateral tissues are stretched out. And there obviously is some contractures on the medial side, so those soft tissues will need to be addressed, appropriate releases on the medial side, tackling the bone defect, and then obviously it would need a certain amount of constraint. So we would have to choose a constrained implant to address the stability.
So who would like to comment on the templating? Do we feel that's let's start the tibial cut. Do we think that's an appropriate tibial cut?
No, I think in diagram, I think I have drawn a little bigger than usual. Yeah. In severe deformity, one should definitely cut less, and I have cut definitely less than that. And similarly on the femur side, I think the cut both sides are a little over than what has been shown. But these cuts are drawn almost roughly 10 millimeters either side by scale without doing a reduction, hence they are appearing a little bigger than what they should be.
Yes, perhaps. So I think the take-home message is I would probably do a 6 to 7 millimeter cut on the lateral side. So maybe it is projectional and I can't see very well, but these are the cases you want to start off with thinner cuts than usual. So who's going to, let me poll the panel, who's going to use autograft to fix this defect? We have one. Who's going to use a sleeve or a cone or something of that nature? We have one.
I'll use a wedge and a stem.
Wedge and a stem. Okay.
If necessary, yeah.
Well, I might build up the bone. I might do a graft. I might get away with that.
So you use autograft. Use distal
femur?
femur?
No, the cut when we make it,
yeah.
I might like to build it up with the bone which I get from the femoral condyles.
From the distal femur, yes.
Yes, from the distal femur.
Yeah, that technique is well described. You take the distal femur, you fix it with two K-wires, and then you can screw. And most of the time, those defects can be managed with that local bone from the distal femur. So tell us what you did.
Yeah, and I like everyone to look at the difference in the lateral view and look at the amount of defect on the left side and somewhat contained defect on the right side. This is what I did. Standard PS prosthesis with screws and autograft, left side. And since the defect was anteroposterior, I used a stem on the left side. And this is the lateral view.
Okay, so who wants to, let's comment on the use of a graft and then the use of a stem. Who likes the idea of using a stem when you graft? We have 1, 2,
yes, I do.
3, 4, 5. So I think the whole panel is suggesting that if you're going to use graft, you should cement it and use a stem. So you did the right thing on one side, and hopefully the other side works. It seems like it was a smaller defect.
I will take issue with the fact that this particular primary stem on the tibia is longer than most. And so I think because of the length of this particular primary stem, I'm not sure that an actual stem would be as necessary. If you look carefully, the right stem is well and fully cemented, whereas the left stem There is less cement on the left stem, even though there's on the left side, even though there's a stem, there's less cement. So let's distinguish between the effect of the stem at mitigating angular forces and its effect in axial force with cement. Just because you have a stem that extends longer doesn't mean that you should not put cement to the same level that you would ordinarily put with a primary knee.
So you make a great point, Jose. I think, there's people who just cement the undersurface of the tibial component. Then there are people that will just cement the undersurface and the metaphyseal sleeve and press fit the stem. And then there's full cementation of the stem. And I think if you're going to use graft and you're going to bypass, you should fully cement the stems in this case.
Can I ask a question, Ever?
Sure.
And the Jose also, because this is a Smith & Nephew system, it's an uncemented stem. If on the table you are having a good fix while impinging the stem, do you still like to cement all the stems?
I think I would in the case of using graft, because graft does resorb, and you want to have that extra support down below in case that happens. Dr. Durrani?
Yeah, if this was supposed to be used as an uncemented stem, then it's too short because it doesn't have the purchase in the...
It had good purchase. Believe me, it had a good purchase. I mean, you try using those stems, they are good solid stem. On the lateral, it appears that way, but in the AP, it appears pretty solid. And you feel like you may fracture going to a bigger stem. Whenever the reemerge starts giving you a feel, you stop there, and there's a right stem. And this is the final picture. 6 weeks post-op, and the patient died yesterday, so almost 8 years post-op, he did well.
Okay, congratulations. Good job.
Thank
You have a question, microphone 2.
Yeah, my concern about putting those screws through the graft. The screws go horizontally.